Lainnya sudah ada? Sudah nyambung. Dr. Akira Matsumori, medical doctor, PhD from National Hospital Kyoto Medical Center, Japan. Good afternoon, Dr. Matsumori. Good afternoon, Dr. Matsumori. Suaranya? Oke, saya bacakan CV-nya dulu. We are incredibly fortunate to have you this afternoon with us today. We sure that your insight will inspire us and enrich our discussions. Dr. Akira Matsumori from National Hospital Organization in Kyoto Medical Center, Japan. He got his medical doctor and PhD degrees from Kyoto University School of Medicine, and he's the founder of current president of the International Society of Cardiomyopathies, Myocarditis, and Heart Failure. He also served as a visiting director in the Clinical Research Center of Kyoto Medical Center and has held key roles such as Secretary of the World Heart Federations and the President of Asian Pacific Society of Cardiology. Additionally, Dr. Matsumori has been an instructor and visiting professor at Harvard Medical School. We are truly privileged to have him with us today. Please join with me welcoming Dr. Akira Matsumori, please. Suaranya belum ada. Suaranya sudah ada.
The level of cardiac function in response to of body movement, along of PLP and anticoagulability, the diagnosis and stratification of heart failure are well established. These biomarkers are also biological tools for screening and guiding treatment in subsequent clinical heart failure. Other biomarkers such as proteins and soluble ST2 show promise for risk stratification, providing information dependent on PLP and independent of PLP and anticoagulability. Additional biomarker being evaluated in correcting 3 growth differentiation factor 15, mid-regional pro-adrenal medullin, and markers of renal dysfunction. Multi-marker strategies and genomic, transcriptomic, proteomic, and metabolomic analysis may further refine heart failure management in the future. These slides show the pathogenesis of heart failure, including ischemic and dilated cardiomyopathies. Dyslipidemia, diabetes, and hypertension promote atherosclerosis, leading to acute myocardial infarction. Infectious agents like viruses or autoimmune reaction can induce myocarditis, which can progress to dilated cardiomyopathy. Genetic mutation also contribute to the development of dilated cardiomyopathy. Both AMI and myocarditis are associated with inflammation, which cause cardiac remodeling and ultimately leads to heart failure. Our previous study demonstrated that activation of renin-angiotensin-aldosterone system induces inflammation in the heart. Agent activating these systems, such as angiotensin receptor blockers and aldosterone antagonists, have been shown to improve heart failure outcomes. Moreover, inhibition of inflammation in myocarditis and anti-allergic drugs targeting mast cell activation reduce inflammation and prevented development of myocarditis and heart failure in animal models. Inflammation is strongly associated with hypertension with ischemic heart disease. We have shown that the expression of interleukin-1 and monocyte chemotherapy protein 1 is significantly increased in the heart of patients with ischemic or hypertensive heart disease. In those associated with hypertensive heart failure, we observed a large accumulation of macrophages in the cardiac interstitium. Atherosclerosis is driven by both lipid accumulation and inflammation. The Jupiter trial demonstrated that patients with CRP about 2 benefit greatly from statin therapy. For a proof of principle that targeting inflammation with canakinumab and IL-1 beta monoclonal antibody improved atherosclerotic outcomes. Further, IL-6 inhibition, iHEFCard, has been shown to reduce and thrombotic biomarkers relevant to atherosclerosis. Colchicine has also been effective in preventing major cardiovascular events in patients with chronic coronary disease. During atherogenesis, humanizing macrophages mast cells play an important role in the inflammatory process. This timeline illustrates major milestones for 40K research into the role of inflammation in atherosclerosis. T is HFDI and the expression of monocyte macrophages, and T cells were identified in atherosclerotic plaques. In the 1990s, pro-inflammatory cytokines such as TNF were detected in the plaque, and high CRP levels were linked to coronary artery disease. In the 2000s, elevated plasma levels of CRP, IL-6, and TNF were associated with worse clinical outcome. More recently, immune checkpoint inhibitors were shown to increase cardiovascular risk, and clinical trials have evaluated anti-inflammatory therapy in cardiovascular diseases. Additionally, studies demonstrated bone marrow involvement in atherosclerosis, the use of single-cell analysis to study black immune cells. Macrophages in the plaque originated from the monocytes, local proliferation, or differentiation of vascular smooth muscle cells. These macrophages take up blood proteins, becoming foam cells that form the necrotic core of plaques. Antigen-presenting cells, including macrophages and dendritic cells, present lipid antigen to natural killer cells and peptide antigen to T cells, triggering adaptive immune responses. This process contributes to the endothelial dysfunction, protein uptake, smooth muscle proliferation, and fibrous cap formation. Therapies targeting innate immunity include IL-1 and IL-6 inhibitors TNF blockers, and P38 inhibitors. Therapies targeting adaptive immunity include local proliferation inhibitors and low-dose IL-2. Therapies targeting lipoprotein includes antibodies against oxidized LDL and related molecules. Broad immunosuppressive agents include colchicine, low-dose methotrexate, glucocorticoids, and hydroxychloroquine. Obesity is central to cluster of disease with significant morbidity and mortality. The mechanistic link to some disease is clear. The connection to other poorly understood. Brown adipose tissue plays a key role in energy and glucose regulation. In contrast, visceral white adipose tissue is a major source of inflammatory markers in type 2 diabetes. It produces a range of pro-inflammatory substances, attracting immune cells and triggering chronic low-grade inflammation, linking obesity, diabetes, and insulin resistance. There is a vicious cycle between inflammation and hyperglycemia. Inflammation and oxidative stress promote insulin resistance, leading to hyperglycemia, which in turn perpetuates chronic inflammation and exacerbates diabetes-related complications. Hyperglycemia occurs more cardiovascular complications by impairing endothelial dysfunction, partly through the induction of vascular cell adhesion molecule 1. Recent infection and inflammation of the oral cavity have been suggested to play a role in the pathways of various diseases. This schematic shows how periodontitis contributes to cardiovascular disease. Inflammation from biochemical imbalance releases mediators like interleukins, prostaglandins, and TNF, leading to alveolar bone loss and eventually allowing for pathogens to enter the bloodstream, promoting atherosclerosis, myocardial and peripheral arteries. Myocardial wound healing depends on the balance between matrix breakdown and synthesis. Matrix metalloproteases regulate inflammation, fibrosis, angiogenesis, and collagen deposition. Corpuscular formation requires adequate inflammation, migration, and proliferation, angiogenesis, and proper collagen deposition. This regulation of these processes leads to poor scale formation and heart failure. This slide summarizes cellular and tissue level alterations that drive myocardial remodeling. Cardiomyocytes, fibroblasts, and endothelial cells and immune cells interact dynamically. Damage alter these interactions, contribute to disease progression. Cardiac troponin are released mainly due to ischemic necrosis, but also due to other stress conditions in chronic heart failure. Natriuretic peptide remain viable markers for diagnosis, prognosis, and treatment assessment. GDF15 reflects myocardial stress, but is also elevated in metabolic and cardiovascular disease. Other markers such as collagen, peptides, MMP, TIMS, cytokines, like TNF, S100 proteins, Direct-T3, and ST2 also provide important information on myocardial stress remodeling and fibrosis. Markers of endothelial activation, like from Wilbrand factor and additional neurotropic sources of atherosclerosis in the heart. In summary, circulating biomarkers offer crucial insight into the mechanism of cardiac remodeling from myocardial infarction or ischemic heart failure. Advances in biomarker research may lead to more appropriate prognostication and personalized therapies, ultimately improving patients' outcome. We are investigating the role of immunoglobulin light chain, FLC, in cardiovascular diseases. FLC, kappa, and lambda are synthesized in cells during the proliferation and assembly of complete immunoglobulin and can circulate freely in the bloodstream. Since FLC reflects inflammation, both acute and chronic, they have potential to serve as biomarker for a wide range of conditions, including non-communicable diseases and other inflammatory disorders. Serum FLC levels may rise due to increased production in bone marrow or lymph nodes, or due to decreased clearance by the ventricular endothelial cells or the kidney. We conducted a study to investigate prognostic marker for longevity in the elderly. A total of 1,105 residents from Shimane Prefecture, Japan participated in health examinations with a mean age of 70 years. Among them, 400 individuals with available 11-year follow-up data were included in the analysis. Significant association with mortality observed FLC lambda, BNP, HbA1c, AST, and an inverse correlation with LDL cholesterol. Logistic regression analysis revealed that odds ratio was increased in HbA1c, AST, FLC lambda, and BNP. Thus, markers related to diabetes, heart failure, and immune function were significant risk factors of death. Using ROC curve analysis, the AUC for predicting survival similar in those markers, notably due to efficient coefficient of FLC lambda was sufficient 14, emerging as the strongest factor influencing survival in the world. High digital coefficient were also observed with kappa, HbA1c, and BNP, reinforcing their importance as mortality predictors. This study shows Kaplan-Meier survival curve and log-rank test results for BNP and LDL cholesterol. Mortality was significantly higher in the group high BNP. Interestingly, for LDL, mortality was higher in the low LDL group. This finding is intriguing and warrants further investigation, and the recent study have reported a J-curve relationship between LDL level and survival, particularly among the elderly. Mayo Clinic demonstrates that combined levels of kappa and lambda FLC associates with all-cause mortality in the general population. Similarly, among patients with heart failure, higher combined FLC levels were linked to increased all-cause mortality. Another study which for patients for 4.5 years found that the FLC levels above 65 RMA below 33 and eGFR below 30 were independently associated with higher mortality. We have shown that the FLC serves as a novel biomarker of chronic inflammation in conditions such as diabetes, heart failure, and myocarditis. The diabetes, atrial fibrillation. The three-direction emerging abnormal biomarker of inflammation, cardiovascular disease, and non-communicable disease. In heart failure myocarditis, circulating kappa levels were significantly lower compared to healthy control, where the lambda level was significantly higher. Consequently, kappa lambda ratio was markedly lower in heart failure patients. The optimal cutoff level for the kappa lambda ratio determined by minimum p-value was 1.86. The ROC-AUC of 0.87 indicates a strong ability of kappa lambda ratio to differentiate myocarditis patients with heart failure from healthy individuals. The Cox operational hazard model showed that higher level NT-proBNP, FLC, lambda, and lower kappa lambda ratio was significantly associated with mortality. Multivariate analysis confirmed that NT-proBNP and kappa lambda ratio were independent predictor of survival. This slide proposes classification based on NT-proBNP and kappa lambda ratio. Kappa lambda survival curve was stratified into three groups according to the NT-proBNP, above or below 30 to 50, kappa lambda ratio above or below 1.5. We compared biomarkers for predicting survival after ventriculopathy in patients with advanced heart failure. This is done in collaboration with Dr. Suma and Isomura. BNP and NT-proBNP demonstrate a strong association with increased risk. The kappa lambda ratio was strong in that association with heart attacks, and FC lambda and interleukin 6 levels showed trend towards significance. Kappa-Meier survival analysis showed a significant difference in overall survival between groups stratified. Kappa lambda ratio using kappa value of 0.6. Patients with a high ratio above this level are markedly longer survival compared to 1150 that were below 0.6. These findings strongest suggest that the kappa lambda ratio, along with BNP and anti-BNP levels, are strong prognostic value for predicting 10-year survival. The ROC-AUC of the kappa lambda ratio are comparable with that of BNP or NT-proBNP, highlighting its potential utility. We also compare ROC-CARD to BNP and NT-proBNP. We did BNP plus kappa lambda ratio and NT-proBNP plus kappa lambda ratio. The combination of BNP or NT-proBNP with FLC ratio proved to be a more sensitive and specific predictor of survival. This slide highlights variation of new predictive model shows significant improvement as evidenced by net improvement integrated discrimination improved metrics. Thus, FLC kappa lambda ratio was a strong prognostic marker in heart failure. And adding kappa lambda ratio improved BNP and NT-proBNP prognostic model significantly. Therefore, FLC enhanced heart failure risk stratification beyond traditional inflammation markers. We compared post-ventricular capacity survival between patients with ischemic heart failure and those with dilated cardiomyopathy. The survival was significantly higher in patients with ischemic heart failure. When comparing biomarkers between ischemic heart failure and dilated cardiomyopathy patients, including inflammatory markers, no significant difference were found. These findings suggest that these biomarkers may have behaved similarly in end-stage heart failure. The mechanistic differences of the survival between ischemic heart failure and dilated cardiomyopathy remains to be clarified. Next, I will discuss briefly with the references and diabetes. Patients with type 2 diabetes, circulating oxygen kappa levels was lower, number higher. As a result, kappa ratio was significantly reduced. Local KUC analysis showed that kappa ratio had the highest value among referencing reagent markers. This compared log KUC autophagy with that of glycated hemoglobin A1C. The AUC for the kappa ratio was 0.996, even higher than that of HbA1c 0.96. We also measured urine FLCs in patients with diabetes. As you can see, there was a strong correlation between urine and the serum FLC levels. These factors for diabetes, such as viral infection, obesity, hyperglycemia, activate NF-kappa, a major regulatory inflammatory expression. Thus, FCR proposed as a biomarker of NF-kappa activation and inflammation. Furthermore, medications such as metformin, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and anti-IL-1 therapies are known to inhibit NF-kappa activation and reduce inflammation. Chronic inflammation plays a crucial role in pathogens many diseases, including cancer, autoimmune disease, gastrointestinal disease, neurological disease, and cardiometabolic disorders. Since FLCs can affect both acute and chronic inflammation, they may serve as useful biomarker for a wide spectrum of non-communicable diseases.
3 more minutes.
Okay, I will show that another point. And until now, no biomarkers have been available for product longevity. Sequential measurement of FLCs may allow us to assess whatever lifestyle change of range of drug therapies are benefits for each individual. Normalization of FLC suggests that the intervention promotes longevity, whereas worsening of FLC could imply a higher risk of earlier death. FLC can serve as important to clinical monitoring diabetes and cardiovascular disease. So, its assessment research and biomarker such as FLC provide valuable insight into understanding of pathological process of cardiac remodeling, oral myocardial infarction, or ischemic heart failure. Advances in the field may lead to improved prognostication and individual therapeutic approaches, ultimately enhancing patient outcomes. Thank you very much.
Okay, thank you, Dr. Akira. Is there any questions from the floor? Okay, my friend Dr. Harisakti has one question for you. I will read the questions. What do you think about some of the latest biomarkers to detect and predict the heart failure prognosis, such as ST2 or galectin? The second one is, what is the role of GDF15 for the heart failure prognostics compared to the NT-proBNP?
we have not measured actually ST2 or GD415, and we don't know what the comparison, which is beneficial or not. We need to more data in the future to compare all these biomarkers in the future, in the data, to clarify.
Okay. I think due to limited of time, thank you, Dr. Akira, for your time, and we proceed to the next speaker. Thank you.